Hi everyone, welcome to our Unit 1 discussion here in ST 135. It's our first week of 7 weeks of discussion. The 8th week won't have one, but this week we're going to be talking about furniture in the operating room and just kind of the basic layout of how the operating room is. So a little bit about me before we get started, so you know who your teacher is. I know with an online course it can be a little bit, sometimes it feels like there's a bit of a disconnect sometimes, but there is a person behind the screen, okay? So like I said, my name is Megan. I have been a surge tech since 2008. I graduated with a certificate back then, that's all you needed. And I practiced as a CST for several years at our local hospital. And then I got the opportunity to start teaching part-time at our local technical center in the surge tech program. And so really since 2012, I've been teaching either part-time and now full-time at our local, same place here in Marietta, Ohio. And then I would decided to go back to get my um, associate's degree in applied science, as well as a Bachelor of Arts. I just kind of kept going. And actually, I'd really like to work on my master's here soon too. So I like to learn, and working in the OR, I think you kind of have to have that trait of liking to learn new things because, the operating room and surgery never stops advancing, right? You always have to learn. So I do have two kids. They're a little bit older now than his picture. This is a few years old, but um, two kids, two dogs, keeps life interesting. So this is a little bit about me. This is me teaching at one of our hospitals. All right, so every week I like to post your assignments just to keep you up to date. If you haven't looked at them already, they are in your syllabus, but here they are again. Okay, so you do have discussion posts due weekly. They are due on Wednesday, your initial post, and then by Sunday, you need to have responded to at least one peer for full credit. Okay, that way you get all the points. I know it can be tricky to go back and remember to respond to people, but make sure you do that so you get the full amount. Shouldn't take too long. Okay, so our objectives for this week are learning the basic equipment, furniture for the operating room, how to utilize those things, how to make sure that those things are available to you in each operating room at the beginning of the day, because this is the foundation, right? If you've never been in an OR, some of you have, some of you haven't. You have different backgrounds, but you need to be able to look for these things every day to make sure your room is ready for your case, for your patient, for your surgeon. So this is the basics, right? So we do have a lot of furniture in the operating room. I don't know if you have a value study where you are. They're everywhere here. So every piece of equipment is vital and has a function. Okay. So it sometimes depends on the case that you're doing or the specialty. Surgical specialties will have different pieces of equipment that are important to their cases. Facilities, maybe you're in a small hospital, a rural place. You may not have the most up-to-date or biggest, bestest equipment that, maybe Johns Hopkins would or something like that. So kind of try to show you both ends of the spectrum throughout the whole thing, but these are basic layouts. This room here over on the right is quite large. That's very nice. Some ORs are not that big. Some of them are half that size. This big room would be really good for things like neuro, orthopedics, open hearts, things that require a lot of extra equipment like microscopes, x-rays. Pulling the equipment in and out takes up a lot of space. You have nice x-ray screens, you have TV screens so you can see what they're doing. So this is just kind of a basic, the center of the room is pretty much always the bed, the patient, the OR bed. Okay. And then everything else is kind of geared around that. Some hospitals only have one door, one opening. Some will have an opening to the outside hallway and an opening to either a substerile room or to like a core area, a common core area. So it really just kind of depends on how your room is laid out because some facilities utilize what's called like a hospital plan where you've got all your rooms in a corridor, or a lot of them, I would say the majority of them are a racetrack plan where you have them in a circle around a racetrack type design. So you could just keep going in loops. So it kind of makes the flow a little bit better. But inside that racetrack, that circle, be a core, the inside, where a lot of facilities will store like sterile items, like a sterile storage area, or sometimes they even put desks in there. Okay, so what are the duties of a surge tech? What are you going to be doing on a daily basis? I mean, I'm sure by now you've probably researched the job at least a little bit to be in the program. You know a little bit about what you're getting yourself into, but as far as the basics go, you have to understand just the basics of the surgery. What are they going to be doing? What position is that patient going to be in for that particular surgery? Positioning changes based on, access, where the surgeon makes their incision, um, maybe patient anatomy, sometimes that changes things a little bit too. But you have to know that positioning ahead of time. That's part of your job because that can change the type of draping you need, the type of setup you might need, um, positioning on the bed themselves, different positioning devices like stirrups you might have to plan for. So knowing all of that ahead of time before you bring the patient back to the room is very vital, okay? You also, in this role, are proactively preventing injuries and accidents. That obviously pertains to positioning, but it can pertain to anything that you do, right? You are the patient's advocate. That's one of your biggest jobs. The patient is typically in a position to where they cannot speak for themselves. They're under anesthesia, whatever. So you're there to speak for them. You're to speak up for them. So if you see something that's not right, that could cause harm to the patient, that's up to you to say that, because a lot of times, especially new students, struggle with that concept of, am I allowed to say this? And are they going to think that I'm, speaking out of turn or whatever? But really, in reality, as a student, they are sometimes looking for you to say those things. They want to know that you know what you're doing and that you're there to take care of the patient. So don't be afraid to speak respectfully if you see something that needs addressed as far as patient care. Okay. And again, question potential risks. If, let's say, um, it looks like maybe that stirrup is too high, right? You could question, it's okay to ask it in a question. I wouldn't be disrespectful in how you approach it, maybe your preceptor, where you can say, does that look okay to you? Or, form it as a question. I think a lot of times that helps. Or, I think that arm board is extended too far. Do you think that their arm is going to hurt like that? Arm board shouldn't be extended past 90 degrees. Okay. So little things like that, you're allowed to speak up to, for sure. And always communicate. If something is not right, speak up. Say, okay, let's fix this. Okay. They're looking for you to do that as a student. They want to know that they can trust you and that you have the patient's best interest at heart. All right, so here are some of our regular pieces of furniture. These are going to be in, I would venture to say, 99% of your cases. I mean, there's the odd chance where you don't need a bed. Okay, sometimes little things sometimes they'll do on the patient's own bed. I just saw it today at clinicals with my other job. They were doing an I&D, an incision and drainage of an abscess on the leg. Quick little case, doctor just wanted to keep him on the patient's bed. That's fine. Sometimes we do that, right? So you can just scoot the bed out of the way. Now, more often than not, you'll have to transfer the patient over to the OR bed. And we'll look at different parts of that bed here in a minute. You also have this back table. There are varieties of the back table. Some of them are called double deckers, excuse me, that have a whole other level. They're a little bit trickier to drape, but if you have a lot of trays and equipment, instruments, you might need that second level, like in ortho or neuro, maybe in open hearts, might have extra things. So that might be beneficial. But back tables are where we're going to put the things we need for our case. Really, that's our starting point. We'll drape this out with a sterile drape, a back table pack. And so everything that you need for that case that is sterile will go on this back table that is covered sterilely. Now, more often than not, you'll also have a Mayo stand, this thing here at the bottom left corner, that raises and adjusts. There's a little knob here at the bottom under this bar that you can put your foot on that raises and lowers this tray. Now, if you put your foot on that knob, you better have a hold of that tray, okay? It will go slamming down. You don't want to do that, especially in the middle of the case with instruments already on your Mayo, okay? I speak from experience. I've done it. I was a student too, or you get tired, you're sitting here, you're standing on this post side, accidentally put your foot there, and everything goes crashing down, scares everybody. So try not to do that. But will get draped out with it kind of looks like the equivalent to a trash bag, okay, but it's folded neatly that you slide over that creates a sterile field here. So the top of this mayo stand is sterile. That's where you're going to put the instruments that you need most frequently during the case will be put here. You can slide this the way it's made here. You slide it over the draped OR bed of the patient. So if we're working up here in the abdomen, a lot of times we'll slide this mayo stand down over their feet. Just watch their feet. You have those to work with. Your back table could be positioned here, like kind of like an L shape, or like a 90-degree angle, I guess you could say, something. And you're going to be standing in between the two. So you have your little workspace with those. And your basin would be next to your back table. So the basin would also get a sterile drape with it as well, because these, as they are right now, are not sterile. They're going to be wiped down between each case. So they're clean, but they are not sterile. So the basin can hold fluids, right? Or sometimes specimens. A lot of cases, the back table pack will have a basin in it, a sterile one that you can put in there with the drape that might already have like your Bobby tip, your suction tubing, light handles might come packaged in that. So you might have that there as well. Then you have this kick bucket that might be what this little thing is here. It looks a little short in this picture, but a kick bucket it's small. It's just like short. We kick it around the room because if you're sterile, you can't reach down and touch something. You have sterile gloves on. So we move a lot of these things on wheels with our feet. That's why it's called a kick bucket. But typically this will have a red biohazard bag in it. That way you can put bloody sponges or soiled sponges throughout the case into this kick bucket. So it should be positioned near you in this room that you could throw into. You really don't want to start putting your dirty or bloody laps or sponges on your back table. The idea is to keep clean and dirty separate. Always keep that concept in your head, okay? Even if your circulator doesn't want to bend over to get them out of this kick bucket, that's where they should go. I've seen that happen, okay? Ideally, they go here. Keep clean and dirty separate. So those are some of your regular furniture you'll see. You can even see it in these pictures over here. It's in every OR. Okay, some other things you might have, most often, at least these two. Almost every room will have some sort of rolling stool. There are certain cases in which the surgeon may sit. If they're doing a hand case and they have to have it like draped out on an arm board, it might be easier for the surgeon and the assistant to sit and have that right there as opposed to bending over to the hand. I've seen several others. If they're doing, let's say, a vaginal hysterectomy and the surgeon is positioned between the patient's legs and stirrups, the surgeon will often sit down there. This is called a step up. You can step these up. You can stack them to, wouldn't imagine more than 3 high. You're not supposed to, because you could fall. But sometimes we have a really tall surgeon and a really short surg tech. So the bed is going to get adjusted to the surgeon's needs. So you may have to adjust and have a couple step ups so you can reach your Mayo stand or your instruments. So those are usually in every room where you have to go hunt them down. And then this is a scope cart here on the right. This can be pulled into different rooms depending on what cases you're doing, but it's where you would hook up your light cords, your endoscopes or laparoscopes, even arthroscopies, anything that you're going to need a scope for visualization and light. It will be on some sort of cart like this. That way they can see what they're doing. And they have, you could print. There's a little printer here if the surgeon takes pictures with their scope. And those would go in the patient record. So you have a screen here to see what they're doing, but often in the OR, they're kind of connected to the ones around the room. The other room, I think they were in the other, this picture doesn't have it, but one of the other pictures showed, go back, see if I can find it for you. Yeah, they're kind of usually hanging from the ceiling. This whole Like these things here hanging from the ceiling, they're called booms. So the boom might have your scope equipment on it as well that just stays in the room, but you also have these extra monitors on little arms that can be repositioned throughout the room as well. So those extra monitors are called slave monitors of the book. Um, so everybody, no matter where you're standing, can see what the surgeon's doing with the scope. Circulator can see, anesthesia sees what's going on, everybody. So those are some of the other things you're going to see. Now here is a picture, a better picture of the bed. This is a really common brand, the Steris Amsco. There might be different varieties or versions, but this is just a very general operating room table. So you'll see some version like this. This is the head of the bed. These really soft foam mats do come off. I would say in most varieties they do, so you can clean them underneath. Sometimes blood gets underneath those. There's a little divot here for cases that you're going to be working down below, like perineum, vaginal hysterectomy, stuff like that. And then you have the foot of the bed. So those are the three main parts. You have arm boards that could be taken off. This bar along each side is what these clip onto. If you had stirrups or legs, they would get clipped onto this metal bar. There's other types of positioning devices that can be clipped on here as well. There is, and you can't really see it in this picture, but kind of here in the middle, there would be a bar underneath this mat, the soft mat, that can be raised by using, there's a little remote or control up here that can be raised. That's called a kidney rest. So if the patient needs like a nephrectomy, we might position them laterally on their side, raise that kidney bar underneath the mat, which kind of hyperextends the hip so you can see the kidney a little bit better. So that pushes that out. There are a few cases that we would put the head on the foot of the bed. This comes apart and put it down here, and we would take both off to access the perineum. So sometimes when we're positioning patients, we're and they're awake and maybe a couple of us are just helping them scoot over, we will say, you're going to feel a little divot in this bed. We want your bottom, your butt, to be right above that divot. You don't want to be in it. You want to be right above it. If they're too far in it, it can actually cause nerve damage if they're there for too long. We don't want that. So we just kind of direct them sometimes on how to do that. So here are some of the things that hole right there, that's called the perineal cutout to access the perineum. So it does lock in place. It raises, lowers. You can raise the head up so the feet are down, vice versa, feet up, head down, Trendelenburg. You'll learn your different positionings. Another important thing is that it has a radiolucent top. That means if we bring in a portable X-ray machine or a C-arm for ortho neurovascular cases usually, that means the X-ray can penetrate through it so we can see the patient's bones or vessels or whatever it is we're doing. The X-ray won't be blocked by that. So it is radiolucent. The X-ray goes through it. You can add footboards here. You can even add shoulder braces up here. So a lot of different functions. You can't see the remote here, but it's usually hanging up here by anesthesia. Typically, anesthesia is going to be in charge of raising or lowering the head of the bed or whatever during the case. Okay. So here's another variety. That was the basic bed. There are a ton of, when we get into positioning, attachments, different beds for different positions. There's a lot of different things. So here are some of your options. These are smaller stirrups. We don't typically use this variety in surgery very often. We have a little bit of a longer one that adds like the foot or the heel as well, or candy canes that go up high. So we don't use these two very often. That's a type of stirrup. You have a different type of headboard. This could be like to hold the drapes out of the way or something like that. These are shoulder braces. These are for like side braces. These legs can raise and lower independently for ortho cases usually. So we also have things that help prevent injuries, like this picture here, or these. They're like little gel things. They're really fun to to mess with. They're really soft. So we want to make sure whenever we're positioning that we're always like double, triple checking how the patient is positioned. We don't want nerve damage. We don't want anything compressed that might comprise vascular supply. So always check to make sure everything would be in a good angle. If it looks uncomfortable to you, it's probably uncomfortable to the patient. If your patient is, let's say, 80 years old, and when you move that patient to the bed and they can't raise their arms while they're awake past a certain degree, don't do that to them while they're asleep. It could very well cause damage. So try to gauge what their normal range of motion might be when you're positioning those types of things so you don't overextend them. So we always want to check for nerve blood vessels, that they're not being pinched. Shearing injuries can happen more often in older patients where their skin slides past something and shears it because their skin is a little bit thinner. So make sure you're careful in how you move them over to something. Pressure injuries, we want to pad any like bony prominence, which would also help with nerves. So if they're laying like this patient is, you want to pad the elbows, the face. We have a lot of different face holders. If they're in prone, their knees are going to be padded, their ankles, feet, all of that gets a special type of padding. If they're laying on the side of their head, there will be a gel donut for their ear so they're not laying flat on their ear. It's not comfortable after so many hours of laying on the table, right? We always have to watch for respiratory compromise. Certain positions, if they're like laying, let's say back on their back, they're in supine, and they have the bed positioned where their head is down, all of those internal organs go with gravity. So those internal organs get pushed down toward the lungs. So if throughout the case, sometimes anesthesia will actually say, we need to take them out of Trendelenburg for a few because their respirations are compromised. So they're having trouble breathing. So every now and then we have to adjust that in the middle of the case so they can kind of bring their stats back where they want them. Okay. So we talked about the normal OR bed. Well, here's your normal bed, but this is a very different type of bed. When you get into orthopedics, especially, they have a lot of different things, different pieces of equipment. This thing looks like it's something straight out of a torture device if you were just looking at it, but it is usually used to work on the lower extremities. It's called a HANA table or a fracture table, used to fix fractures, usually in the femur, lower leg. So these are independent of each other. They can move one up or down. They're in a little foot thing that pulls traction. So they can work on those broken bones. There's a padded post in the middle. You want to make sure it's padded. Okay, you might be doing a knee case, maybe a total knee. They want some sort of knee support. There's different varieties of this as well, but this hooks directly onto that rail. But make sure anything like this with a turn knob is tight. Always, always, because if it falls in the middle of the case with the patient on it, that could cause damage. Be very careful. So this is a hand table attachment. It goes right on that edge. Like I said before, if they're doing a hand case, that normal arm board is pretty narrow. That's not going to be enough room for them to work for if they're doing like carpal tunnel or something like that. They need a little bit more space. So we have a wider variety of that hand attachment. And then this is called a peg board that would go on top of the main OR bed, but it has pegs in it. It's got these foam posts again, but this is hard plastic where the holes are. So we put a thin-ish gel mat down for the patient to lay on. And then we'll also pad between the legs and the arms, make sure there's no nerve damage up here on the shoulder. They have a foam holder for the head. So, and this actually gets like ratcheted down almost to the post as well, so the board itself isn't sliding around. So we would use this if they were doing something laterally, maybe a hip case up here, right? So these are orthopedic specialty things. All right, so patient transfer devices. How do we get our patient to and from the operating room bed? So that can be tricky sometimes. A lot of times our patients are coming in on a stretcher, a gurney, or just a train, like a transport cart. It wouldn't be like your normal OR bed. They would come to the the holding area there where they were waiting into the OR in the stretcher more often than not. Occasionally they might come in a wheelchair if it's not a big case or something minor. They can, however, come to you on that bigger patient bed that you would see like on the floor in ICU. If they have to come from an inpatient, they might just keep them on that and wheel them down in their ICU bed or whatever. But more often than not, it's a stretcher. To get that patient from that bed or stretcher to the operating room bed, there's a couple ways we can do this. There is one called an air-assisted transfer system. That's what this is. I'm pretty sure it's called a hover mat. Some facilities prefer that. It's a little easier for some of our larger patients, our patients that have limited mobility. Transfer boards could be like a roller board or a thin piece of plastic that you put a drape sheet over and pull the sheet. And then the mechanical hoist would be for much larger patients. I actually have not used mechanical hoist, so I don't know too much about that. But whenever you're transferring patients, it's really important to make sure that you follow the direction of anesthesia. So I know looks like it's in PACU, but whenever we're to or from the OR bed, you always check with the anesthesia. They're the ones that are going to give you the go ahead. They're going to count to 3. On 3, everybody moves together. So if the patient is unconscious, they're not awake, they can't move on their own, whatever it is, you have to have a minimum of 4 people, 1 on each side, anesthesia at the head and somebody at the feet. If they are mobile, like they're first coming in, they're still kind of awake, they can kind of help scoot themselves over, you need a minimum of 2, 1 on each side, so they don't go too far off that narrow OR bed. Okay, so 2 for an awake patient, 4 minimum for an asleep patient. All right, so special procedure rooms. So you have your basic ORs. Occasionally you might have specialty rooms that only do certain things, like a cysto room. That's really common in a lot of places because there's a lot of little specialty things that you just don't want to have to be carting to every single room. So if you can have it all in one place, it's a lot nicer. Sometimes it's in the main OR or just right outside of it. In our facilities here, it's within the main OR, the cysto room. So it's got the bed set up for cystoscopies every time. It's got the x-ray already available, all the stents, catheters already all there. So that's really nice. Usually very close by to the OR is a cardiac cath lab. So that way, if something does go wrong in the cardiac cath lab and they do need to do something more invasive, the operating room is right there. They can just cart them right over. Minor procedure rooms might be in or near. Usually a lot smaller rooms that might be for things like even scopes. We use ours for sometimes small ENT cases. We have a pediatric dentist who comes, skin lesions, small things like that. And then your emergency department should be very close as well because, a lot of our trauma patients have to come to surgery and you want that to be easy access. So I have this video here of this operating room just to give you a better visual of, this one's relatively new, of how this particular one is laid out. So just pay attention to the pieces of equipment, things that you see. Just a quick little video.
I'm Meryl Taylor. I'm the robotics coordinator and a circulator here at St. Peter's Health. We have all sorts of new features here in our new operating suites. The patient can have a different experience now with the newer rooms because we are able to use newer technology to take care of patients. For instance, the robot. We wouldn't have probably been able to utilize that with our old room. Now we're able to do different surgeries that we weren't able to offer to the community prior to this. We upgraded to become the state-of-the-art OR in Montana. We have the newest, latest equipment. We have a routing system that we are able to hook different OR equipment into. When you're having an arthroscopic or laparoscopic surgery, the camera that goes into your body, that picture is routed to these screens so that the surgeon can see what they're looking at, and so can everybody else in the room. They have a great crisp 4K picture. One of the lights has an in-light camera. We're able to route that so that the people outside of the surgical field can see the operation. There's two different, what we call greetings that we play, so that when people come into the operating room, it's a little bit more welcoming. It plays calming music, or we can play music that the patient requests when they come in. And that way they just feel a little bit more at home. It's better to see a nice rabbit or a river than all the instrumentation and all the strangers staring at you. We have these state-of-the-art lights that are LED. That means that they don't add extra heat to the surgeons to the field, so that when they're shining on the field, they're nice and cool. These smart readers in the room are able to tell us what our airflow is, the temperature, the humidity. We have a new air handler that's able to handle all 6 operating rooms on the same air handler. The positive pressure allows all of the air to move away from the field, so there's nothing that is going to float back into the field. We also have these new pass-through cabinets. If we need additional instrumentation or supplies, we can call out of the room, and a person in the sterile core can come and put a item in the pass-through, close the door, then we can open it from the operating room side and not disrupt the airflow in the OR. We have green lights in the room that when we are doing any type of arthroscopic or laparoscopic surgery, we are able to have those vessels and that anatomy kind of pop a little bit more because it shows the redness better. We have ultraviolet 3 lights that turn on when there's nobody in the room, that kills the germs while we're not doing anything. So there's always antimicrobial work being done in the OR. With this new renovation, we're able to use newer technologies in the spaces. We can just utilize all the technology that's out there.
Well, I like that OR because it's pretty up to date. So you're going to see similar things like that where you go to do clinicals, hopefully. If not, maybe within the next year or so. Especially those OR lights that are LED. I tell you, that makes such a huge difference. They didn't used to be LED, and they would get very hot. So that is a nice, and the green light to show the vessels is a huge benefit. So I just wanted to show you some of the nicer things that you might see. Okay, so really that's it for our OR equipment discussion this week. If you have any questions, please feel free to reach out to me. My email is mludwig@herzing.edu. I do have office hours on Tuesdays, 3 to 5-ish. If that doesn't work, you need to talk, just let me know, or shoot me an email. I'll get back to you as soon as I can. So good luck starting out this quarter. Let's do this quarter right. So again, have any questions, just reach out.